Hi, welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
And I'm Dr. Brad Weaning.
Brad, today I thought we could just, for our viewers, break down Tiger Woods' recent injuries.
Okay, yeah, his injury and his treatment. Obviously, it took the world by storm yesterday. Yesterday morning, he was in a very tragic car accident. Thankfully, the word so far is that he's doing okay and that he got out of surgery, but certainly has a long road ahead, and a lot of people are concerned and worried about him. There's a lot of terminology that I saw on the news that probably didn't make sense to the average person, so we thought we would break it all down as much as we could with the information that we have to share what we know.
Yeah, first and foremost, Tiger, please get well. We enjoy watching you play golf, and really sorry for your injuries. And we didn't know where to send a get well card to, so this is your get well card.
Get well from Talking with Docs. Yeah, horrible, obviously, for anyone for this to happen, but obviously for him being in the public eye and being a dad like we are, and yeah, it's just a very difficult time. So, okay, let's start at the beginning. So, he had a rollover in his car. We don't know exactly why. It doesn't really matter to us, but he was pinned in the car for a little while. His legs were crushed, and then he was extracted through the windshield apparently, and then went to a level 1 trauma center, which is where they are experts in treating high-level trauma. And he was diagnosed with a couple of different injuries. So injuries to both of his legs, and his right leg particularly had 2 compound or open wounds and a comminuted proximal and distal tibia fracture, as well as a fibula fracture.
Lucky for us, Dr. Weaning was there so he could witness all this. That's how he could roll that off the top of his head.
That's right.
Big golfer?
Yeah, I love golf. And you know what? Tiger Woods is definitely not everybody's favorite golfer, but you know what? I think he's really changed the way he's approached golf and life, and I think he's really in the hearts of all of the golfing world for sure. So,
okay.
Let's explain some of this stuff, Paul.
Let's break it down. Okay, let's talk about first what bone. What are some of the bones that were involved in this injury?
So there were 2. So the tibia, which is like your shin bone, the large bone on the inner part of your lower leg, and then your fibula, the long skinny bone on the outside part of your lower leg.
Okay, and we're going to look at an x-ray in a minute to help break that down, but we're just going to cover a few topics first here. So that's the bone that was involved, tibia and fibula, and they were fractured.
Yes.
Fractured means they broke.
Right, so broke, cracked, fractured, all the same thing.
Right.
Okay.
And then they described some comminution.
Yeah, it's fun to say.
Read my lips, comminution.
So what does comminution mean, Paul?
Comminution means scientifically broken into lots of little pieces.
That's right, so more than 2 pieces. So it could be 3, could be 10, but that really explains more the amount of force that went into breaking that bone.
Right, so if there's a lot of comminution, more force was required, and it's harder to put together sometimes when you have a lot of comminution.
The other word that I heard was compound. And that's a word that you and I don't actually use a lot anymore, but what does that mean?
Compound, that word is sort of evolved now, and we use the term open instead. It means that for a moment in time, the bone stuck out of the skin. Okay, right. Bone was exposed to the atmosphere. Bone doesn't like to stick out of the skin. Why doesn't bone like sticking out of the skin?
Well, because there are bad things outside of the skin that it is vulnerable to, particularly bacteria.
Right. So as soon as you have an open fracture or a compound fracture, you're at increased risk of infection.
Yeah, so that's really a big part of the urgency for getting someone to the operating room relatively quickly.
Yeah.
Often in a 6 to 8 hour window if it's possible.
Yeah, we've if you have a fracture, sure you want to treat it as quickly as possible, but you have a few days before you can treat a fracture. You have time to treat. But if it's compound, now we say open. If it's an open fracture, you want to get in quickly because you want to get that bone covered up again.
Right. So does it mean, Paul, that when the people got there, do you think they could see the bone sticking out of the skin necessarily?
There's different grades of compound or open. So in a grade 1 or a small open wound, you might not see it.
Right.
It might be just a little puncture wound. But in something like a grade 3, it could be just visible. You're looking at the tibia. You break the windshield, look down, and there's Tiger Woods' tibia looking at you.
And the thing about the tibia, if you look down at your own legs right now, a lot of times, particularly the inner part of the tibia, does not have a lot of soft tissue coverage. And that's why it's prone to open wounds, to troubles with the soft tissue, as well as infection. So let's specifically talk about the compound or the open fracture. What does this mean for the fracture itself, like long term? Does this make it worse?
Well, I think it can make it take longer to heal.
For sure.
Because you've had a lot of the soft tissues stripped. And if you strip off the soft tissues, you challenge the blood supply to the bone.
Yep.
And now without a good blood supply, it could take longer to heal.
And that has a name.
A delayed union?
A delayed union.
Yeah.
And I think it also, that lends itself to the next thing, that sometimes the delay is so long that the bone can actually not heal. So even though it's been in a cast or had surgery or whatever, the two pieces of bone or multiple pieces of bone don't connect together, and then you can get what's called a non-union that requires another whole set of specific treatments. So that's potentially way down the road. We don't talk about that today, but open fractures, compound fractures make that risk higher.
Okay, so you had an open or compound comminuted fracture, the tibia, and how are we going to treat this?
So if you were in a place where there was not surgery, you might try to treat it in a cast, but usually that is not successful for multiple reasons, particularly because it's open and because it's unstable. So this is an injury that requires an operation.
Yeah, and we learned a few decades ago that the best way to treat a tibia fracture is with a rod.
Right, we used to use plates and screws.
Yep, now we use a rod, and that's called an intramedullary nail. Inside, medullary, inside the bone inside the canal, intramedullary nail, IM nail. So we put a rod right down the tibia.
Because the tibia is hollow.
Fun fact, you know where we got this technology from?
I do, from the Second World War. So I know, I'm good.
Jeopardy here.
So a lot of the pilots, when they crashed, they ended up, it was more broken femurs, I believe, than broken tibias.
Yeah.
And so wartime surgery, they actually tried it out. And originally, some of the other countries, even their pilots were being treated by the host country.
Yes.
And they thought this was some
courtesy.
kind of
it's a courtesy. It's a courtesy.
But they thought it was torture. People were coming back and they had these rods in their legs. They're like, wow, these people are being tortured. But really, they were actually advancing medicine by recognizing that if you can put the metal inside the bone, it actually could protect it better.
Yeah, so the POWs came home and they had these rods in their femurs and tibias, and turns out that that's sort of a technology that evolved from, there's a silver lining.
The only silver lining of war, I think.
Yeah.
There you go, IM nails.
Yeah.
Okay, so Paul, when you go to the operating room, so they probably call ahead, they say, hey, we have an open fracture, we'll come to the OR. What else do they do in preparation? Is there anything different about this kind of case as opposed to something that goes into a scheduled time?
Oh yeah, well it's done urgently,
yes.
Right? You're gonna do it urgently, and you're gonna, first thing you wanna do is just irrigate and clean the bone that's sticking out. If there's any gross contamination, like Tiger Woods golf pants might have been on there.
For sure.
You'd have to remove those, remove any contaminants, any bits of car that are around
dirt,
the wound,
grass, whatever.
Remove all that stuff off the wound, clean it really quick as best you can, cover it up with a wet dressing, get into the OR, and antibiotic coverage as well. We often start some antibiotics empirically right away. And
then often they would confirm tetanus status.
Tetanus.
Yeah. Make sure that your vaccines are up to date, give you a booster if required, that kind of stuff. Okay,
and then I would, first thing you're going to do once you get everything cleaned and covered, you get an X-ray. You want to go take a look at some X-rays?
Yes. Yeah, let's look at some X-rays now.
How'd you get a hold of Tiger Woods X-rays?
These are not Tiger Woods X-rays. Full disclosure, these are a broken tibia. His X-ray likely looks very different and actually potentially has more fractures, particularly up top on this X-ray, but it gives you an idea of what he's going to get. So we'll take a quick look. Okay, so let's go take a look at some X-rays. So you can see here, this is a fracture of the distal tibia and the fibula. The X-ray on the left is a lateral X-ray, and the X-ray on the right is an AP or a front to back X-ray. This is not exactly the same, but according to the reports, Tiger Woods had a fracture of his both distal and proximal tibia, as well as his fibula. So you can see that the joint line is not involved in this fracture, but you can clearly see the angulation and the fractures of both of those two bones that will need to be fixed. Surgically, Tiger Woods had an intramedullary nail inserted, as well as some types of screws or pins put in distally. We don't know exactly the details, but you can see here the fibula has been fixed with a plate and multiple screws, and you can see a rod inside of the tibia. 2 screws were put in the distal surface, 2 screws through the nail to lock it to control rotation, and then up here is where the nail is actually put in. It's put in through the knee. You can see 2 screws up there also to control rotation. So it goes inside of the hollow bone to control movement.
So there were some X-rays that we looked at, not Tiger Woods specific injury, but a fractured tibia that was treated with an IM nail. Any questions? Good. Let's move on.
Okay, so you go to the OR. Do people go to sleep for this, Paul? Do they have a spinal anesthetic? What do they do?
You can have a general anesthetic or a regional anesthetic, like a spinal anesthetic. Check out our videos on spinal anesthetic if you want to see what those are. now in Tiger Woods' case, he's had extensive spine surgery in the past.
5 of them, unfortunately.
Yeah, so if I'm the anesthetist in that case, I'm probably a little worried that I might not be able to get that spinal anesthetic in the exact right spot.
Yes.
Because of the fusions in that, so potentially he might have had a general anesthetic.
And then some freezing to help with the pain.
Sure, some local freezing, sure.
Okay, so you get in there and you prep and drape it, so you get the leg ready and you have portable x-ray in the room, and you already know what kind of fracture, you have your implements ready. Do you do anything for the wound? Like, do you have to deal with that surgically?
Yeah, we do a debridement, right?
Okay.
We call it a sequential debridement, right down from the skin right down to the bone. We debride any contaminated tissue, and then you keep your fingers crossed and hope that you have enough tissue to cover up.
Right, so you just kind of clean the edges.
Yeah, sometimes you lose a lot of the tissue,
Yes.
and you need to get the help of your plastic surgeon colleague to come and bring some tissue from other local regions or remotely and cover up that wound.
Right.
So we want to make sure that we debride adequately, and hopefully we have enough soft tissue coverage to close our wounds.
Okay, so we got our wound clean. Now we have a leg that's probably unstable and actually can move around a fair bit. And so we know in his case he actually had a broken ankle as well as a broken upper part of his tibia.
Yeah.
Do you start with the tibia or do you start with the fibula?
Typically, when you have an ankle fracture, we typically start with the fibula because we want to get it out to length.
Right.
That helps you get the length out.
Almost gives you like a template.
Yeah. But they're two completely different approaches. The fibulas, you make an incision right over the fibula to put your plate on.
Yep.
The tibia, where most of the action is away from the fracture, at your entry point, where you're going to put that IM nail into the tibia.
So how do you get a large metal rod into his hollow thigh bone from his knee?
Right, with the help of X-ray.
Yes, critical part of it.
We use it's called fluoroscopy. When you have live X-ray in the OR, you get images, and we kind of know where our starting points are. We're to make a hole in the proximal tibia up just below the knee.
Right.
And we insert the rod. And then do we just insert the rod, or do we have to prepare that tibia first? I had to swing to ask him a question. He's got me on the hot seat.
Yeah, so you make an incision usually either on the side of the patellar tendon or the tendon that connects the kneecap to the shin bone, or sometimes right in the middle of it.
Yeah.
And then using X-ray, like you said, you identify the front part of the tibia where you're going to enter, and usually enter it with some type of sharp device that will go through bone. So like an awl, actually, is what we call it.
Well, we all use an awl.
We all AWL. And then in order to prepare the tibia, one, to clear out some of the debris from the canal itself, as well as to determine the size, you use what are called reamers. So using a battery-powered drill and a long, flexible, circular drill, almost like a roto-rooter kind of idea.
Roto-root the tibia.
You go until you can't put a bigger size in. You hear what's called chatter. So you're here on the hard bone, and then you know what size it is, and then using X-ray, you measure the length.
Yep.
And then you open up one from the shelf.
Yeah, like a shoe, right? You size the tibia, so you have different lengths of rods, 300 millimeters, 280 millimeters, 250 millimeters, and different diameters, 7 millimeters, 8 millimeters, 9 millimeters, 10 millimeters, 11 millimeters, typical numbers for a tibia.
Yep.
And it's a reamed nail. You do reaming and then put the nail in.
Right.
And then, in the old days, you'd sort of stop there once you got the nail in, but as this technology evolved, we realized that we lock these.
That we lock it. And so just back to the length, we actually wanted to fill most of the tibia too, right? So on X-ray, we can see that reamer goes right down to the ankle. You don't want to go past and into the ankle. Obviously, that would be bad. But you want it to span almost the entire length, particularly if you have fractures above and below.
Yeah.
So the locking. So why do you lock? What do you mean by locking?
We lock it because what that means is to put some transverse screws across. You saw them on the X-ray around the top and the bottom to hold the bone from pistoning on the rod.
So the nail already has holes for these screws?
Yeah.
Okay.
You line them up and you put in these screws through the bone, through the nail, so that it locks it in and also stops rotation.
Controls rotation as well as impaction. Okay. So now we've got his fibula plated. We've got the tibia nailed. Now, while we're putting that nail in, if the tibia is angled and we put that reamer across, do we have to hold it straight while we're doing that?
Yeah, we reduce. That's called a reduction.
Okay.
Right? We reduce the fracture, try and get it back as close to aligned as we can get it.
Right.
But of course, also putting the nail in also does some of the reduction.
Sure, it takes some force.
Yeah. So you want to line it up. You want it to be sort of straight in both planes, lined up, locked, and that makes it stable.
And what's nice about having X-ray in the operating room too, you know exactly what you have when you're done. So you're happy that the fracture is aligned, that the length of the nail is okay, that all the parts are where they're supposed to be. Now, go ahead.
I was going to jump to post-op, but I have a feeling you still got.
I got
more
one
to
more
do in
thing.
your
So the
OR
other
here.
thing that they reported in the news, that his doctor reported in the post-surgical press conference, is that he had to have a soft tissue release for extensive swelling. He was not using non-medical terms on purpose, I suspect. But what do you make of that, Paul?
Yeah. So he's describing a fasciotomy.
Right.
Fasciotomy. So basically, what can happen when you have trauma is you have a lot of swelling, and your muscle tissues are normally engulfed in fascia, or layers that cover tough fibrous tissue that covers the muscle.
Like the sheath on like a sausage almost.
Sausage sheath, exactly. So your sausage sheath gets quite tense if the sausage starts to swell, right? And as that thing swells, it can actually suffocate itself. So you have to release that fascia.
Right, so worst case, if you didn't do something for that, you could get something called compartment syndrome, which lots of people have probably heard about and potentially even have looked up since this injury.
Yeah.
And that could, compromise the blood supply or the nerve supply to the muscles and even lead to killing them.
Yeah, we're preventing a compartment syndrome, right? And that's devastating. You could lose the leg in that sense. Could Tiger have lost the leg with this injury?
100%.
Yeah, that's a risk. He's lucky that he still has his leg, right?
Especially if he would have been stuck in the car for a prolonged period of time.
Yeah. And he's not out of the woods yet. Sorry.
Yeah.
Infection sets in.
For sure.
You know, something he still has, he still has to be careful moving forward. And let's talk about that now.
Okay? So post-op. So he gets to his hospital bed. So I'd say the first two priorities for him are going to be antibiotics control infection.
Yeah.
Actually, three things. Elevation, ice, compression to try to reduce his swelling, keep a close eye on that. And then 3, to control his pain.
Yeah.
Is this going to be painful?
Oh yeah. This is a painful fracture.
Yeah.
Fourth thing is when can I golf again? That's going to be his first question, I think, coming out of this.
Yeah.
In my sort of imaginary vision of Tiger only thinking about golf all the time.
So the thing that's going to complicate that is a couple things. So one, the severity of this injury, the open wound, the fasciotomy, but also apparently his other leg is broken too.
Okay, that's unfortunate, right? Because you need one good leg to stand on.
So that usually means walker. Sorry, it means probably wheelchair.
So the question before you can answer when am I going to golf, when am I going to be able to walk again, when am I going to be able to train again, when am I going to be able to run again?
Okay, so let's start with walking. Do you let someone walk on your nail, the rod that you just put in?
In a straightforward tibia fracture with an IM nail in it, I would let someone, after I operate on it, I let them weight bear as tolerated.
Right.
His is a little more complicated. He's got a few more injuries there. He's got the fibula fracture, there's comminution, and the soft tissue challenge that he had. So I would protect, in my hands, I'd protect his weight bearing, not let him walk on that side. Probably for at least, somewhere between 3 and 6 weeks before I let him start weight bearing.
Right, so he'll be followed with regular x-rays to assess the bony response to the surgery and to the injury. And then once you are happy, then let him put some weight up, maybe partial weight to start and then progressing to full.
Yeah.
Okay, what about the soft tissue? Now that he had this soft tissue release, we don't know if they were actually able to sew the skin shut or if it had to be left open, which sometimes happens, which will really change the long-term prognosis and healing time. Whether plastic surgery had to be involved, and I suspect they probably came in and took a look, is my guess. At a center like that, they probably called their team and said, can you take a look? They might not have done anything, but they're prepared to, and a lot of unknowns, to be honest.
Yeah, there are, but these are things that we're hypothesizing could be happening down the road if he doesn't need to have that closed again. And then,
what's the fastest time it's going to take to heal this bone, probably?
This bone, this is one of the slower bones to heal, just because of the poor soft tissue coverage. So, at best, if you saw good healing somewhere in the 3 to 6 month mark,
agreed.
Then you're like high-fiving, you're doing great with a tibia fracture.
And the wound's healed.
So in his case, the things that I'd be worried about, we'll just go back and forth.
Yeah, for sure.
One thing I'm worried about is infection. Is he going to develop an infection?
Right. So what are we going to do to prevent that?
We're going to give him some antibiotics. He might need more surgery to clean it out. Or he may need extensive antibiotics. So infection. What are you worried about?
Number 2, even though we did a fasciotomy, we'll keep a close eye for things like compartment syndrome, because there are actually 3 compartments in the lower leg. We don't know if they released all 3. So really keep a close eye on his swelling, because also, if your leg's really swollen, it makes it hard for those soft tissue wounds to heal. So too much tension, that compromises the blood supply as well. So
so I'm going to watch for that.
Swelling.
I'm going to watch for a DVT. Okay,
Yes.
I'm worried about a blood clot because we're not going to let him walk on it for a while. I don't want him to get a blood clot, so we might get some form of blood thinner to prevent a blood clot. A blood clot that stays in the leg, no big deal, but if a piece breaks off and goes to your lungs, it could be fatal. So we're going to worry.
That's called a pulmonary embolism.
Worried about that.
And the nice thing is they did not mention that he did not have a vascular injury, which is a very real possibility with these kinds of fractures. He could have lacerated an artery from that fracture, so that's very likely. So that's number 3. Number 4 is the bone healing. So whether or not, when we look at x-rays, does it look like the fracture lines are getting less visible? Is there any sign of bone being made? And the one thing potentially you'd consider would be something to augment that, whether that's, he's for sure going to have good nutrition and a team of specialists around him, but potentially a bone stimulator or something extra to kind of upregulate the bone cells to make some more bone.
Yeah, sure, a bone stimulator. And other complications, worry about a pneumonia or something because you're lying around, you're not clearing your lungs much. You don't worry about pneumonia or some sort of urinary tract infection or other things that come with just sort of not being able to move around too much.
Okay, so let's say, theoretically, say we're 4 months down the road. The bone's healed, the wounds are clear, he didn't get a blood clot, his swelling's okay. What else are these people going to face? Obviously, you can't just get up and start going for a 5K jog after this happens. What's going to be a problem?
His new best friend's going to be a physiotherapist.
Absolutely.
An athletic therapist, a team of physiotherapists, athletic therapists.
How do you rehab your tibia?
Well, it's the tibia doesn't need so much rehab as all the muscles around it, right? The knee and the ankle, basically, we're going to, remember, we didn't let him move for a while. He was going to splint and unlock the muscles atrophy. They go away. Even Tiger Woods' muscles are going to atrophy.
He's jacked too.
Right, he is. He trained with the Navy SEALs for a while. So I watched that documentary.
Oh, I didn't watch it.
It's good. Yeah, you should watch it. Yeah,
I heard good.
But he's going to need to rehab all his muscles. So he's going to need extensive physiotherapy for a while.
Yeah. And then obviously you have to keep an eye on pain control. So whether that's a combination of narcotics or anti-inflammatories or other medications for sure.
And he has, I know, had a challenge with pain medication.
From his back.
His back. He had extensive back surgery and he did have some challenges with managing that pain and there is some suggestion of maybe some narcotic dependence that develops in him after all that pain management. So he's going to need narcotic pain medication definitely in the first while after. So that's going to be a challenge as well.
For sure. And then obviously you first have to learn, like it sounds cliche, but you got to learn to walk before you run, and you definitely got to learn to walk and run before you play golf.
You got to learn to putt before you drive.
For sure.
He's a good putter though.
He was a clutch putter, for sure. Clutch everything.
Yeah.
So yeah, that's one challenge. And then I know something that people are going to be wondering, and maybe even Tiger will be wondering, is this stuff going to stay in him forever?
Right, you mean the golf skill?
That will always be there, I believe that. But what about his hardware?
Oh,
so
yeah,
the metal
the
rod and the pins and screws and all that stuff that we put inside.
Yeah.
Because a lot of people are like, I don't want this in me. It's foreign. I don't like it.
Yeah.
We have a video on this specifically.
Should I get my hardware removed?
Should I get my hardware removed? So A, should you get it removed? And if he did, when would you take it out?
Yeah, okay, good question. So should you get the hardware removed? The answer is sometimes yes, sometimes no. If it doesn't bug you, leave it in there.
Agree.
Okay. But if it does bother you, like your ear, some of the screws can be irritating in the subcutaneous tissue, then you would want to take it out. But you wouldn't want to take it out until
you have complete union or healing of the bone. We want that to make sure that it's doing its job.
Right, and the magic number, we say 2 years. Typically, we say wait a couple of years before you take it out.
Yes.
Okay, so when and if you think he's going to be able to golf again, what's your take?
So he's Tiger Woods, right? So my guess, I'm going to go a full year. I'm going to go Masters 2022.
Nice. I think it might be a little bit. I think he will golf again.
Yeah, so do I.
At a professional level, but I think it's going to be a bit longer than a year personally.
Well, it's 14 months, April. That's longer than 14 months?
Maybe a year and a half, I'd say. Just because he's also got the back issue. He
hadn't even healed from his 5th surgery yet.
No, I mean, I think he'll golf before that, but before we see him competing, I'm going to give him 18 months. But I see.
And obviously, we wish him nothing but the best. And there's lots of people pulling for him. He's got a great team around him, so I suspect he's getting excellent care.
Yeah.
And what we'll do is, we'll keep an eye on this, and we'll do a follow-up. If there's something else going on, or if there are questions, please, let us know. And hey, if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
Get well, Tiger.